Dear colleagues, today we present the case of a fetus affected by early onset fetal growth restriction. This is a fetus in the 25th week of amenorrhea. We proceed to take measurements of the cephalic end and observe that both the biparietal diameter and the head circumference are below the 3rd percentile. We then proceed to perform the Doppler of the middle cerebral artery, which in this case, while it is normally a vessel that shows high resistance, here we find a waveform that is generally reduced with a well-defined diastolic phase. We then proceed to perform all the necessary measurements for fetal biometric assessment, and we will see how even the transverse scan of the abdomen with the measurement of the abdominal circumference shows a biometric value below the 3rd percentile for the gestational age. In this case, we will always rely on the trace in order to achieve the most accurate measurements possible. We will now also proceed to perform the femur biometry, and during this process, we will see how this particular measurement too is in line with all the other regions, ultimately falling below the 3rd percentile. We will therefore perform a Doppler assessment of the uterine arteries, and we can see that the uterine artery on this side shows a protodiastolic notch, that is, a protodiastolic indentation, and a pulsatility index that is elevated for this gestational age. On the contralateral side, we will instead assess a uterine artery that is almost within normal limits, but it should be noted that the pulsatility index must be considered as an average, and therefore, overall, we will have an average pulsatility index that is elevated for the gestational age, a typical Doppler flow pattern of the uterine arteries in cases of early growth restriction. In this case, we can also see that the placenta shows microcalcifications, and this, together with the growth restriction, should prompt us to consider possible infectious or even genetic pathology as a cause, which should be ruled out if necessary through amniocentesis and maternal serology. But let's also see how, even just using color Doppler at the level of the umbilical artery, a complete absence of diastolic flow is evident. In this case, let's remember that in the management of early growth restriction, it is fundamentally important to perform a Doppler and flow assessment of the ductus venosus, which represents the fetus's last line of defense in the mechanisms of compensation and adaptation to chronic hypoxia. In this case, we can see that the wave is present, but the pulsatility index of the ductus venosus is increased. Obviously, we will also assess the amount of amniotic fluid by evaluating the 4 quadrants, that is, the vertical pockets of fluid in the 4 uterine quadrants, excluding fetal parts and the umbilical cord. These are the first 2 quadrants. The 3rd and 4th quadrants. By measuring the vertical pockets, the total will be given in centimeters. The minimum limit is 5 centimeters, the maximum is 25. In this case, it is about 9, so we are not yet in oligohydramnios. I will now show you the biometric charts. You can see how it is very easy to clearly visualize an overall weight below the 3rd percentile, with all the anomalies, all the measurements below the 3rd percentile. Of course, we must always remember to assess the first trimester CRL, but in this case, also consider the Doppler flow alterations. The picture of early growth restriction is clear. Thank you all for your attention.